All right, so I'm going to talk about the fundamentals from an integrative perspective. Here we could see the anatomy of prostate cancer itself and how it could result in complications by pressing it into the urethral stricture that goes from the bladder to the penis, and why you see that urinary complications are not only a concern of prostate cancer, but due to the treatment as well. Because as you destroy this tumor, for instance, you see over here, you could see that it's quite easy to damage these nearby structures. So what I'm going to be doing is just generally talking about from A to Z, facts and statistics, all the way down to diet and nutrients. A lot of this you perhaps may already be familiar with, but I tried to update everything from what we currently know through to 2026. So let's talk about the data. So approximately this year in 2026, in the United States, about 313,000 men are projected to be diagnosed with prostate cancer. And we talked, well, you all talked earlier about PSA screening, but that's actually part of my discussion here. It is the most common cancer in men other than skin cancer. And when I gave this presentation with this group in 2023, the estimate was 288, 300 men. The incidence has been increasing by 3% annually, not because we're getting more prostate cancer, but actually because we're catching up from a fundamental and tragic mistake that was done in 2012 when the US Preventative Services Task Force recommended against routine PSA screening. This actually started a little bit earlier, back in 2010, where they suggested, well, we don't have data for men 75 years and up, so we just shouldn't test them at all. And then in 2012, it became more restrictive. They give PSA testing itself a recommendation of D, meaning that it does more harm than good. And some of their logic was it may give men some unnecessary fear and anxiety. That's certainly legitimate. If a man has an enlarged prostate, then it's normal for PSA to be somewhat elevated. A normal prostate is around 20 cc's or 20 grams, and we expect a PSA with that size of a prostate to be around a 2. If a man has a pretty enlarged prostate around 60 cc's, we may expect a PSA to be around 6, which is elevated. PSA goes up to a 4, but that's still potentially a benign condition. So a man who does a PSA with a 6 and his doctor says, well, I think you have prostate cancer, well, that may potentially cause a lot of unwanted anxiety and fear. But here's the problem with that and not testing PSA. Prostate cancer is treatable when you catch it localized and early. When it becomes metastatic, it's no longer treatable and curable, it's manageable. You're now in a lifelong situation where you're trying your hardest to extend someone's life. So we could see on this chart to the right that around the time they stopped suggesting PSA testing, what we found is a surge of people with metastatic distant prostate cancer that were not caught when it was localized and early, when it could have been potentially cured and treated. Instead, those men were left in the dark until they eventually were diagnosed with metastatic prostate cancer, and you could see that as substantially increased. So in 2028, they reversed the decision and they changed the recommendation from a D to a C, meaning that, yeah, I guess you could test PSA if you want to. We no longer don't suggest it, but we're not really encouraging it much either. And so we're still seeing some backlog of these people who were missed quite some time ago that weren't the, even today we have doctors that aren't testing PSA. The problem, as we see though, is that if it's not treated and managed early, then it becomes potentially catastrophic. So about 1 in 9 men will be diagnosed with prostate cancer in their lifetime. About 1 in 40 men will die of prostate cancer. About 77% of prostate cancers present with localized disease, about 11% with regional disease, and 5% with distant metastatic disease. And about 50% of those eligible for active surveillance may safely avoid treatment for 10 years. So on the right here, what we see are autopsy reports based on age, them finding people who have died and saying, well, how many of them have prostate cancer? And you could see from this chart that if you live long enough, it's not a matter of if, it's a matter of when. Essentially, the incidence of prostate cancer does substantially increase with age. When you get to about 100 years old, there's about near a 100% chance on an autopsy, they're going to find prostate cancer. But even so, that's not to be pessimistic because the majority of cancer that they find in these autopsy reports are low grade groups. They're, for instance, grade group 1 or Gleason 6. So they're not likely to be clinically relevant. But regardless, they are still there. And you could see that some people suggest not to test when an individual is, say, quite young. But we could see that, an individual who's died early, there's actually large incidence of prostate cancer in their situation. So whatever is going on in their health potentially may have contributed to that. And that's why me and my organization are actually a big proponent of testing in the context of educating people that it may not necessarily be cancer. It's just the first step to understand, okay, well, we have something we may want to look into, something that we need to do perhaps some further investigation in. Perhaps it's benign, and if so, okay, well, we'll just monitor your PSA over time and see what happens. So 83%, this is some good news, about 83% of prostate cancers are discovered at a local and regional stage. And this is a very high survival rate, near 100% 5-year survival rate for local prostate cancer, and a 97 15-year relative survival rate. So what this is telling me is that if we catch prostate cancer early through routine PSA screening, that people could live a very long life. And a lot of these people can be under active surveillance where they don't even need treatment and they just monitor their situation. We could see the mortality rates for the different grades of cancer on this chart right here. The one at the top is grade 3C, so without being metastatic, that's the worst one. But you could see the predicted probability of prostate cancer survival, or mortality, I apologize, is actually relatively low for these early stages. It's because oftentimes localized early prostate cancer is very survivable. And even when we get an intermediate stage, there's a lot of options. And even if we have a localized aggressive cancer, it's still treatable. There's still a lot of options that we have for that. And the problem is that when it becomes metastatic, we still have treatment options, but that's no longer curable. They don't like to use the word cure in oncology because there's always a chance of reoccurrence. But the reality is that once a prostate cancer is metastatic, we're now dealing with, there's always exceptions, but we're dealing with a lifelong disease. And that's not something that we want if we could avoid it, which is why I'm a big fan of early testing. Because here's the bad news. Metastatic prostate cancer is far less survivable. And these are pessimistic numbers because this is based on old data. We have new treatments coming out every single year. I'm going to talk about those. And these numbers don't reflect those new treatments. And the majority of new treatments are for people with metastatic prostate cancer, once prostate cancer is spread outside of the prostate to nearby surrounding tissues. But we could see once prostate cancer is spread outside of the prostate, the 5-year and 10-year survival is much more pessimistic. We don't even know how many people live past 15 years with metastatic prostate cancer. But again, we have more options now compared to what these numbers reflect. So these numbers are pessimistic. And one of the main treatments when people get metastatic prostate cancer is hormone therapy to decrease testosterone and starve prostate cancer. The problem is, though, is that the prostate cancer becomes resistant to these drugs. And again, it's not a matter of if, it's more so a matter of when. And oftentimes it's about 2 years before men become resistant to these drugs. And that doesn't mean that there isn't any more options at that time. For instance, there's now more options now compared to even a couple of years ago. And so if we could have someone live comfortably for another couple of years, there's additional treatments. And in those 2 years, perhaps even more treatments will be available for them, as a lot of prostate cancer treatments that men do are old treatments, but we also have new treatments too. So this is a really pessimistic slide. Things are much more optimistic than what it suggests. My emphasis here is that if we could catch prostate cancer when it's localized, you could see that it has much better outcomes. It's much more treatable. We're in a much better situation. And so I'm going to discuss some of the causes and risk factors of prostate cancer. So prostate cancer, unlike most other cancers, is actually highly genetic. Twin studies show that 50% of the risk is attributed to genetic factors. meaning that it's possible you may just be born with one of the genes that significantly increases your risk of prostate cancer. And we will talk about there's ways that you could test for that. But we could see at this chart to the bottom right, all these different genes that are involved in prostate cancer. You have a BRCA2 gene, for instance. Well, about 25% of prostate cancers have that BRCA2 gene associated with them in their development. So if you add these up, you could quite see that a lot of these can be
But
contributing
small.
factors.
I understand.
Now, just because someone has a genetic risk factor doesn't mean that they're going to get prostate cancer. It's just one of the overall factors. And we'll talk about ways that we could potentially even manage that genetic risk. Other non-modifiable risk factors are age. The older you are, the more likely you are to have it. We saw that earlier with that autopsy report. And unfortunately, Black men just have an overall higher incidence than white men, are diagnosed at an earlier age, and have double the mortality rate. So screening for them is particularly important. And one could say, okay, well, don't do PSA, instead do MRIs. And that's perfectly fine. But are you going to do an MRI every single year of your prostate? That's expensive for the insurance companies. They're not going to want to cover it. That takes a lot of time. That takes 30 minutes to an hour for each MRI scan. PSA testing is cheap and inexpensive. There are some modifiable risk factors, though, things that we could do or address to help with our risk and our situation. For instance, body weight. Obesity is a 40% higher risk of having advanced prostate cancer. Insulin resistance contributes to both prostate cancer development and progression, so managing proper blood sugar control. Physical activity is something that could be helpful. Exercise. Smoking is a detrimental factor. A diet high in fats, that's low in vegetables, and high in dairy is a contributing factor as well. Environmental toxins, and then sleep apnea is associated with a 34% increased risk of prostate cancer. So if you're not getting enough oxygen to your system, you're not doing you much good. In addition, there is a concept called epigenetics. And what that means is that our diet and our lifestyle influence the expression of our genes that regulate cancer. All these genes that we talk about here in this chart at the bottom right, they in all different ways control cell division and apoptosis or programmed cell death. And we could influence this genetic activity by eating a good diet rich in fruits and vegetables, high in flavonoids and polyphenols, those different colors of fruits and vegetables, and not creating an inflammatory state, which we'll talk about in a moment. So you could test your hereditary risk. This is just one example. There's a company called Myriad Genetics, which I have no association with, but they offer a test called MyRisk, where you could see if you have a gene that increases the risk of prostate cancer. Even if you have prostate cancer, this is still a useful test to do because I'll talk about later on how there's treatments available for some of these genetic variants that increase risk, that give you more options in your toolbox if you need it. Now, if you're under active surveillance, that's not so important unless you have a BRCA mutation. But if you're intermediate risk or advanced risk, you want the most tools available for you, and this gives you another option. And then with intermediate and advanced cancers, we could actually look at the different characteristics or mutations of the cancer itself. Because while rare, some cancers do have specific mutations that allow drugs to be very effective when combined with androgen deprivation, or if and when androgen deprivation therapy or hormone therapy stops working. And I gave an example of two companies that offer that type of testing. There's others as well, especially those big university cancer centers have their own testing. But a couple examples that you could ask your doctor if they're not doing this already is Caris Life Sciences and Foundation One. And again, I have no association with these companies. Here's one example of a Caris Life Science molecular profiling report where you could see they identified certain mutations in this individual's cancer that's unique to them, but they found different drugs that are effective for their specific situation. So looking at your genetics and the genetics of the cancer itself is a way to individualize your treatment approach if necessary and if needed. So high blood sugar and high insulin are modifiable risk factors. Men in the highest incidence of insulin resistance are almost 3 times more likely to have prostate cancer than people who have good, healthy blood sugar regulation. And when you're in a fasting state, really the range goes all the way up to about 25, but really you don't need much insulin if you're fasting because it brings sugar into cells. So an ideal fasting insulin is less than 5. This is something you could test on your lab work in a fasting state that you could do through your doctor. And we know that fiber has anti-inflammatory properties. It reduces insulin growth factor bioactivity, and high fiber intake is inversely associated with prostate cancer risk. In addition, there's endocrine disruptors such as bisphenol A from certain plastics. Microplastics are a whole unknown factor in how they potentially may be influencing our risk here. And certain workplace hazards such as xylene, toluene, benzene, styrene have been associated with an increased risk as well. So let's talk about prevention. And I can't say that diet and lifestyle is going to prevent cancer, but there is research showing that they can provide us with some benefit. One way to prevent advanced prostate cancer is PSA screening. Again, if you could catch it early and localized, yes, it may have highly aggressive features, such as be perhaps a later grade group. But if you could freeze it or cut it and radiate it before it spreads elsewhere, again, there's a possibility of reoccurrence, but you're potentially in a curable situation. Different hormones can influence prostate tumor growth and promoters, such as dihydrotestosterone, estrogen. So looking at your hormone situation could be a way of helping to manage your overall health. Controlling and managing inflammation. There's two main enzymes, fat 5-LOX and COX-2, that increase inflammation. They convert, for instance, inflammatory acids such as arachidonic acid from saturated fat into inflammatory prostaglandins. And there's different ways to regulate that inflammation to slow down these enzymes, such as having a good diet with spices like curcumin, good healthy fish. Boswellia could help manage inflammation, aspirin, enzymes. These different nutrients, such as fish oil, curcumin, soy, resveratrol, green tea, quercetin, those are nutrients that have been shown to regulate our epigenetic expression, meaning that, okay, you have a BRCA2 gene that says you have a higher risk of cancer. Well, you could control that genetic activity by having a good diet and lifestyle. And again, a good diet isn't going to prevent you from getting prostate cancer. But if we could manage the risk of aggressive prostate cancer or help you get into a more optimal situation, why not? And we suggest a Mediterranean type of diet that's rich in pomegranate, green tea, broccoli, and curcumin. And these nutrients, when combined together, have been shown to slow down PSA progression and help to support a healthy, more optimal PSA. I'll talk about that research in a moment. Meta-analysis and population studies have shown an increase in the relative risk of prostate cancer in men with a history of clinical or systemic prostatitis. That's inflammation of the prostate. We could see inflammation as a driving factor in chronic degenerative conditions, including cancer. Infections are hypothesized to play a role in development of cancer as well, due to the regulation of inflammatory markers. You could ask your doctor to test your inflammatory state, actually, by doing a blood test called C-reactive protein. The high sensitivity ideally should be less than 0.5 or less than 1. But you could see how much inflammation is in your system. So there's a hormone that your body converts from testosterone called dihydrotestosterone. And it was initially thought that these drugs that block dihydrotestosterone may increase the risk of prostate cancer. But we actually found that instead, they shrink the prostate and just make it easier for prostate cancer to find. So these drugs are actually not harmful in that context. They allow for easier identification of different lesions that allow us to potentially identify if prostate cancer is there. So some people just overconvert their testosterone into dihydrotestosterone. It's the hormone associated with male pattern baldness. So if you have that in your family history, or if that's something you've experienced, it may be worth testing your dihydrotestosterone to see if it's elevated. And perhaps that's one way you can manage inflammation of the prostate, because they do shrink the prostate by about 50%. What we have found out is that high temperature cooked food increased the risk of advanced prostate cancer. Even just having 1.5 servings of pan-fried red meat per week increases the risk of advanced prostate cancer by 30% compared to people who don't. And people who consume 2.5 servings of red meat cooked at high temperatures are 40% more likely to have advanced prostate cancer. And that a higher consumption of any amount of ground beef is associated with a 130% increase incidence compared to people who do not regularly consume it. This does not mean that you shouldn't have a good, nice cooked steak as an occasional treat, but if you're eating one of these every day, well, you're not putting yourself in a very good situation. Especially because prostate cancer is different than other cancers. You may have heard that sugar feeds cancer. Well, prostate cancer actually feeds off of fats. The majority of its metabolism is fatty acid oxidation. And one of the main fats that's been associated with a higher risk of prostate cancer and advanced prostate cancer is choline. And one of the main ways we get choline is with egg yolks. It's a very rich source of choline, which is why they found that men who consumed about an egg a day had a twofold increased risk of prostate cancer compared to men who didn't eat eggs. And men who consume more than 2.5 eggs per week, which is not a lot, showed an 81% increased risk of prostate cancer compared to people who just ate 1 egg a week. Um, One of the old ways they used to determine prostate cancer metastasis is with a radioactive choline scan. They injected people with radioactive choline, and because prostate cancer that spreads to other tissues, such as bones, is still prostate cancer, they eat this radioactive choline and glow brightly in the imaging. This test is no longer really used because we have better tests nowadays. I'm just bringing this up as an example about how we could see directly how prostate cancer loves fatty substances. So here's a list of some of the foods that are highest in choline, and one of them that isn't listed here is shrimp. And I'm not saying you shouldn't avoid these food or you shouldn't consume these foods, because we don't want to have a choline deficient diet either. We do need choline for brain health. It's a precursor to acetylcholine, a neurotransmitter that's important for memory and cognition, and it's important for liver function and the production of stomach acid. I would argue what we shouldn't have, though, is a high choline diet. So these are foods that ideally should be an occasional treat. The one I would argue that should be an exception here is fish, because fish has anti-inflammatory properties, generally speaking. So I would really just take that off the list. But our diet really shouldn't be heavily concentrated in these foods because they contain nutrients and fats that prostate cancer loves. So we suggest more so a Mediterranean diet or a vegan diet or a pescatarian diet. So the question then is, okay, well, can diet reverse prostate cancer progression or reduced risk? And there's been studies on this. So the consumption of arachidonic acid in red meats and egg yolks produces inflammation. I gave you one example, the 5-LX enzyme. And inflammation interferes with cell regulation and promotes cancer growth and development by inhibiting cancer cell death, a process called apoptosis. So in the Ornish study, they took 93 men with biopsy-proven prostate cancer, and they had elected to not do conventional treatment. They were randomly assigned to an experimental group and a control group. In the Ornish study, it's an omega-3 essentially, a fish-rich diet. And after 1 year, the PSA levels decreased in the group who made comprehensive lifestyle changes, but they increased in the comparison group. And what they found in the serum of participants that it inhibited prostate tumor growth by 70% in the lifestyle change group. And this wasn't just an omega-3 rich diet, this had lifestyle interventions as well. But we could see direct evidence in the PSA levels and in the tumor growth that good, healthy diet and lifestyle could have benefits in our situation. So another study looked at 733 men with prostate cancer and about 1,000 men who didn't have prostate cancer. Average age was 66 years old. Study was over 5 years. They collected a bunch of data and they put them into 3 groups: standard American Western diet, prudent, just kind of middle of the ground, and a Mediterranean. And essentially, the Mediterranean diet included a high intake of fish, fruits, vegetables, boiled potatoes, legumes, olive oil, with low levels of juice intake. And then they measured how much people were adherent to the diet. And what they found is that people that were highly adherent to the Mediterranean diet pattern, it was significantly associated with the reduced risk of having prostate cancer and aggressive prostate cancer and extensive tumors. They didn't find that in any of the other dietary patterns. In a different study involving about 50,000 men that were followed for 24 years, they found that overall, the Mediterranean diet had a 22% lower risk of overall mortality or death. And that's actually, it seems low, but it's actually quite substantial. A recent study examined about 2,000 men. They looked at them about 31 months after diagnosis, or about 7.5 years. And they showed that the people who ate the most amount of plants, or fruits and vegetables, had a 52% lower risk of progression and a 53% lower risk of reoccurrence compared to the people who eat the least amount of fruits and vegetables. And this was even better when they combined it with exercise. They had even better results than the people who did at least 3 hours of brisk walking per week, which is an odd way of measuring it. Essentially, running or highly more aerobic exercise counts for more of these hours. It's not necessarily 3 hours of activity. For instance, 30 minutes of jogging is equal to 1 hour of walking, from my understanding. But essentially, they found out that people who are highly active had better options or better progression. Found that alcohol increases the risk, processed meat increases the risk, and nuts and seeds lower the risk of and mortality of people with prostate cancer. Uh, One study showed that in men who consumed five nuts 5 or more times per week after prostate cancer diagnosis had a 34% lower rate of overall mortality compared to those who ate nuts and seeds less than once a month. Meta-analysis have shown that higher nut intake is associated with a 13% lower risk of cancer mortality risk. And in one study where they gave them flax seeds, it resulted in significantly lower tumor proliferation rates, which there's a test called Ki-67 that a doctor could order to see how rapidly your tumor is potentially dividing and progressing. In addition, in a study of about 2,000 men diagnosed with non-metastatic prostate cancer, individuals with the highest intake of plant foods and the overall plant-based diet intakes had a lower risk of progression compared to those with the lowest intake. Exercise could be helpful too. They took 52 men with prostate cancer under active surveillance. They did 12 weeks of 3 times a week supervised aerobic sessions on the treadmill. They're about 63 years old. They measured various factors, but what they found is that it improved peak oxygen consumption, decreased PSA levels, decreased the velocity or the increase of PSA over time compared to not doing this. In addition, in a relatively recent study, what they found is that resistance training could counteract the negative effects of hormone treatment. So one of the main conventional treatments of prostate cancer is to lower your testosterone to essentially zero, or as close to it as possible. And you can imagine that has a significantly negative effect on your muscle mass, your mood, and energy. And they found that people who did a good amount of resistance training were able to retain their muscle mass and their muscle strength compared to people who were not on hormone replacement therapy or are not on androgen deprivation therapy. So there's ways that we could help to manage some of these adverse effects of treatment. So what are the signs and symptoms of prostate cancer? Well, one of the reasons I'd argue for PSA testing is because in early prostate cancer, there's none. About 60% of men with prostate cancer may not have any symptoms at all at the time of diagnosis. Instead, potentially the only sign of disease may be an elevated PSA. For some men, the tumor could be felt during digital rectal examination, but I'll talk about that in a little bit. That is probably one test that should go by the wayside. I'm sure a different doctor would argue completely differently, but I would argue the PSA is much more valuable than having someone stick their finger up our rectum. The problem is that when prostate cancer becomes advanced and metastatic, is that's when you get the symptoms associated with it. When you get calcification of the tissue, when it presses into the ureter, when you get discomfort, when it spreads to the bones and destroys the bones. So in essence, there's really, for the majority of people in early prostate cancer, there are no signs and symptoms. So again, that's why I'm a proponent of, at the very least, PSA testing. So how is this diagnosed? Well, PSA, we could look at velocity, doubling time, the amount of free PSA, digital rectal exam. Here's the thing. We could look and PSA detects 82% of cancers. That's only 55% for digital rectal exam. That's not to completely dismiss it, because sometimes the digital rectal exam, when the PSA is higher than optimal, say you're running a 3.5, 4.2, if you do a digital rectal exam and you could feel something, well, that's perhaps an indication, well, maybe you should get an MRI. However, if your PSA is higher than optimal, you should get the MRI anyways, I would argue. Why not find out, okay, well, is there something there or not? I would argue for a lot of people, the digital rectal exam, if you're doing a PSA, why is it needed? Well, if you have a high PSA, the next step would be a multi-parametric MRI, because what that gives us is a score called a PIRAD score. It stands for Prostate Imaging Reporting and Data Systems. It gives us a score from 1 to 5, where the algorithms say, okay, 1, this is not cancer. 5, this is most likely cancer. And then, anywhere between 2 to 4 is like, well, okay, we're not sure. So essentially, in addition, according to the Prostate Cancer Research Institute, if we don't see prostate cancer on the MRI, because it's not 100%, but the prostate cancer we don't see on an MRI tends to also be not clinically relevant either. Without the combination of both the PSA and an MRI gives us a very good ability to detect prostate cancer and determine if the biopsy is even needed. And that's sort of the benefit of doing this type of testing, is that sometimes we could avoid a biopsy. If, for instance, we have a high PSA, the MRI shows, okay, we just have an enlarged prostate, but there's no nodule. Well, then I would argue you don't need to do anything further. Perhaps just, continue to monitor the PSA. But if it does show a nodule and it gives us an estimate of how likely it is cancer, that could determine, okay, well, if we got a PIRADS 4 or 5, we probably should do a biopsy, which is really the only way to know what's going on. And some of the men I talked to are concerned that prostate biopsies spread cancer, but that's actually been researched, and it's shown to be negligible, less than 1%. Those needles are so fine that it just does not result in cancer spread. The immune system picks those up and destroys them. So the multiparametric is the most accurate, non-invasive technology to evaluate localized prostate cancer. There's zero radiation. An alternative to an MRI is a multiparametric ultrasound, which is nearly as effective. These are scans that do require a doctor's prescription, but they're non-invasive. They don't involve radiation, and they're very effective for determining the risk and the need for potentially doing a biopsy. In addition, the benefit of biopsy samples is we could see how aggressive it is. We could see its grade group. We could do testing to see how necessary treatment is, for instance. In addition, if we are going to do a biopsy, there's better ways nowadays to do it. And that's by using an MRI and ultrasound beforehand, so that rather than doing 12 random samples, if we see something suspicious, we could directly sample that instead. And they'll typically will do about 3 to 4 surrounding samples too. But if we could identify a suspicious nodule with imaging and target that directly, well, why not? Transperineal biopsies, so kind of the older way, but still, I would argue probably the most common is transrectal biopsies. The risk with those is sepsis, as you're going through the rectum. Transperineal biopsies go through the perineum, so there's far less risk of sepsis. The way that they kind of manage this nowadays is they just give everyone with transrectal biopsies antibiotics, so that kind of avoid acts more like aggressive cells. So the modern way of doing this is the grade group system, which we could see here, which puts us more so the low risk, intermediate, favorable, unfavorable risk, and high risk. Essentially, if you're a grade group 3, which is Gleason 7, 4 plus 3 or higher, you're going to be treating it in some way. A grade group 2, well, they could do testing to see if it's on the aggressive side or not. And so perhaps maybe that could just be active surveillance. And then grade group 1, the majority of time is just watchful waiting. And we could see that in regards to managing survival rate in regards to these different grade groups. And this is after they're treated with a radical prostatectomy, that we have in the earlier grade groups a much higher survival rate in regards to biochemical recurrence survival. But again, this is old data, because now we realize that even if prostate cancer is treated through radiation, and if it reoccurs, we could actually do radiation again. It was thought that you couldn't do that, but the latest research shows that actually you can, and oftentimes it's still quite effective. So the question is, well, if you're kind of in that intermediate category, well, what do you do? Do you do something like remove your prostate or radiation when you're not sure if it's going to be aggressive? And there's some tests that actually could tell you that information, that are FDA approved, that your insurance will very likely cover. So if you're in a grade group 2 or 3 or a Gleason 7, there's tests like Decipher and Polaris that tell us, well, how likely is hormone treatment going to be beneficial for you? How aggressive is this likely to be? Should you actually treat it? And so these are great tests to determine, okay, well, maybe you don't need aggressive treatment for your situation, even if you're in an intermediate favorable risk group. So what are the conventional treatment and emerging strategies? I'm actually not going to talk about conventional treatment much at all. I'm going to talk more so about some of the newer or some of the more innovative options. Conventional treatment, really, the majority of it is this chemical castration, reducing your testosterone down to zero or close to it to starve the prostate cancer. And then you have radiation, and then you have prostatectomy. If you go to a radiologist, they're going to suggest radiation. If you go to a oncological surgeon, they're going to suggest surgery. They have about equivalent outcomes and adverse effects. In my opinion, radiation is a little bit better in regards to urinary outcomes, but they're not that much different. So typically we have active surveillance, just monitoring the situation for low-grade group. Intermediate or advanced is prostatectomy, removing of the prostate, or radiation. And then some of them are given androgen deprivation therapy for either 4 months to a couple years afterwards. And then with a metastatic or high-grade group, they're given the androgen deprivation for the rest of your life. So until about 10 years ago, most men with low-risk cancer had surgery or radiation. But over time, we realized that the majority of these people could actually go a long time with active surveillance. And generally speaking, if prostate cancer is going to progress into a more aggressive group, it does so within the first 2 years. So as long as within that first 2 year period, we're monitoring PSA and doing another MRI and perhaps even another biopsy, we could see if it stays in a low grade group, grade group 1 or Gleason 6. And oftentimes those people can go quite a long time, such as up to 15 years before getting treatment. And so it is possible that low grade groups can become more aggressive, but that risk is on the low side. So in a study of 18,000 people, they showed that with the low grade group or people under active surveillance, that they received grade reclassification at 5, 10, and 15 years was 21%, 30%, and 32%. So again, the majority of people are going to remain grade group 1 and just remain under active surveillance. In addition, the grade group 1 or low risk, they showed only about a 1.5% chance of metastasis rate after 15 years. And here's the thing is if prostate cancer is localized and it doesn't metastasize, you're very likely going to die of something else than prostate cancer, such as cardiovascular disease. The majority of people with localized or low grade group prostate cancer don't die of prostate cancer. So some alternatives to removing the prostate or doing radiation of the prostate that are some of the newer options, and these are studied at big schools such as UCLA and USC, and they are FDA approved, are cryotherapy, where you freeze the prostate cancer. This is only currently available if you only have 1 or 2 lesions on one side of the prostate. If the prostate is completely covered with cancer, they're not going to do cryotherapy. But if you catch it early and only have 1 lesion, it's possible they could freeze it. Another possibility is using high intensity focused ultrasound. There was actually a large study in Australia that was completed where they found minimal adverse effects. Now, these treatment options called focal or localized therapy, because they're not systemic treatment, they're just treating the cancer itself. They're not 100% effective, they're about 80% effective. But here's the thing, if you could avoid radiation and surgery in 80% of cases by doing these instead, well, that's a much better option because you're going to have less urinary and less erectile complications. These are still newer, so there's more research that needs to be done. But from my understanding, based on the Australia research and based on anecdotal reports from customers, is that you still have the risk of erectile dysfunction with cryotherapy. That seems to be less of a risk with high intensity frequency ultrasound. In addition, if you're part of the 20% where they don't completely eliminate the cancer, it reoccurs in 20 years, well, at that point, you could do radiation or surgery if indicated. So this is a good first step if eligible because it has less adverse effects. It's a local focal therapy, and you're going to have less urinary complications and potentially less erectile complications too. So one of the newer ways to look for prostate cancer metastasis is called a PSMA scan. If you're potentially concerned you may have metastasis in your system and your doctor isn't already running this scan, you should ask them to do so because it's much more sensitive than MRI. PSMA stands for prostate-specific membrane antigen. This is a radionuclide that's mostly specific to prostate cancer. And prostate cancer, when it spreads outside and gets to the bones or in organs, it's still prostate cancer, even if it's in those areas. So essentially, it binds to prostate cancer cells and glows brightly on the imaging, telling us if we have metastasis. In addition, lately they developed drugs that could be delivered using this scanning technique, this PSMA, that could target prostate cancer. So even if you have advanced prostate cancer and it becomes resistant to the androgen hormone drugs, there's now, and these have been really approved in just the past few years. Well, Pluvicto a little bit longer, but it's only been really available in the past couple of years. We now have three options that can give us additional treatment if people become resistant to their androgen deprivation drugs. We have Xofigo, which is only really good if it's spread to the bones, but Pluvicto could be useful if it's spread anywhere in the body. And then if Pluvicto, even if that starts working, a newer technique called Actinium, which is a little bit more harsh on your system, but when Pluvicto stops working, it gives you at least one further option to help you live longer. Um, so Actinium is the newest one. And essentially it's for people where they just stop responding to everything else. And what they found is that compared to people who didn't receive Actinium, and again, these are people that they didn't respond to anything else. There's nothing left. What they found is it did extend their life overall survival from 7.9 months to 15.5 months, which may not seem a lot, but they're living twice as long. So, that's another option in our toolbox if indicated. In addition, one of the reasons to test cancer genetics, if we're in a more of an intermediate or advanced situation, is because there's different characteristics where the FDA has recently approved last year some drugs that target those variants or mutations. And I will be honest, the majority of prostate cancer does not have these mutations or variants, but some do. But if you do and you have intermediate or advanced prostate cancer, you're going to want to know because there's more options for your toolbox. One of them is Keytruda. They found that those people had progression-free survival, meaning no reoccurrence of prostate cancer, or the prostate cancer stopped progressing, was 41 months compared to 7 months, people who weren't on Keytruda. So in people where everything pretty much stops working, this is another option, essentially. The thing is with Keytruda, you're only going to qualify. You have something called microsatellite instability. That's the MSI. But again, they could test for that with those genetic testing we talked about, such as a Foundation One or Caris Life Sciences. Another drug that's been recently improved are PARP inhibitors. If you're born with a BRCA mutation, which you may be familiar with as increasing the risk of breast cancer, someone would remove their breast if they're found to have a BRCA mutation. Well, guess what? Men could have a BRCA mutation too, and that increases the risk of prostate cancer. Well, if we do have a BRCA mutation, these drugs called PARP inhibitors tend to be quite effective and could be added in addition to conventional treatment, or when conventional treatment stops working, this is something that may extend lifespan. And again, these two options are recent FDA approvals. So in regards to managing some of the side effects, there's one option for radiation called SpaceOAR that puts an injectable material between your rectum and the prostate to protect your rectum. And this gel material leaves the body after about a couple weeks to 6 months. Some radiologists don't like to use this because the risk of rectal complications is low anyways. I would argue, though, that if you could reduce that even further by 50% and not need depends to go out and walk out in public, why not do it? So if you're getting radiation, it makes sense to ask your doctor about SpaceOAR to lessen the chance of rectal complications. Again, those are relatively low, but on the other hand, you also don't want them. The most common side effect of hormone treatment is hot flashes. Hormone treatment introduces male menopause. So you get some of the similar symptoms that women go through when they get menopause. And hot flashes is the most common symptom. Even so, only about 50% of men get hot flashes on androgen deprivation therapy or hormone treatment. However, recently they found that there is a drug that's been available since the 1970s called oxybutynin that significantly reduces hot flashes. They measure hot flashes with a certain score, but essentially it brought people from an average of 18.23 down 13.95 points. So a substantial reduction in the amount of hot flashes those men were experiencing. And those can be uncomfortable, but again, not all men get these. But if you are experiencing this as a side effect with hormone treatment, ask your doctor about oxybutynin. You may feel more comfortable. The most common side effect of this drug is a dry mouth. There's an over-the-counter option called Xylament that could help with mouth hydration if that occurs. Dry mouth is also the most common symptom of PSMA treatments because the PSMA, again, isn't 100% specific to the prostate. It can irritate the saliva glands too, so dry mouth is a common side effect. So I'm going to talk a little bit more about dietary and lifestyle considerations. Exercise could help manage the side effects of treatment. A higher body mass index has been associated, for instance, with a significant increased risk of aggressive prostate cancer. In men who got prostate cancer, those who gained more than 30 pounds were associated with a 60% increased risk of prostate cancer-related death among people who they already were non-smokers. So managing your weight could be very important in your overall approach and your care. What they also found is that exercise not only improved quality of life, but reduced fatigue caused by the medications. And it also reduces the side effects, such as muscle weakness. And so exercise is very important for not only managing prostate cancer aggression risk, but also progression too. Meditation and stress management have been found to be helpful too. Multiple studies have evaluated this. They've shown improvements in anxiety, depression, cancer-specific distress, quality of life, and sleep quality. People on mindfulness, stress-based stress reduction showed less cancer anxiety and uncertainty, and also less cancer progression too. Now, I admit the study was quite small, but they took people on a plant-based diet, combined it with mindfulness-based stress reduction, and they found a significant decrease in the rate of PSA increase after intervention, substantially increasing the amount of PSA doubling time. In a recent phase 2 trial, on men on active surveillance, a diet high in omega-3, such as fish, and low in omega-6, such as red meat, had a significant decrease in their prostate cancer tissue cell division or aggressionness index, the Ki-67. And again, that is a test you can even ask your doctor to do on the biopsy sample if you want to know that information. And this doesn't necessarily mean that you have to do things like meditation. What we know is epinephrine or adrenaline is a driving factor in prostate and in overall cancer progression and development. So any way that you're able to incorporate stress management, I would argue would be a good thing, such as deep breathing, meditation, prayer, and book reading, anything that's able to get you in a calm, relaxed state. And one of those ways also to do that is what we're doing now, social and group environments, talking with one each other, learning from each other. This has been studied as well in prostate cancer patients that participate in sports clubs, gyms, religious groups, and other groups' activities were all associated with lower mortality risk after adjusting for other factors. When we look at these things, this looks complicated, but HR means hazard ratio. For instance, a hazard ratio of 0.82 means that there's an 18% less risk of mortality in that group. Religious groups, that's about a 17% reduced risk of mortality. And so, socializing with each other is also important as well. So I'm going to be very brief here. There's been different nutrients that have been studied to help with managing PSA progression. And again, I'm just going to go through this quite rapidly. One of them is vitamin D. It's very important for immunity. Have your doctor test your vitamin D. We think we get it through sunlight, and that's true, but that significantly decreases as we age. As we age, the majority of vitamin D is synthesized by gut bacteria. So especially if you have any gastrointestinal symptoms, have your doctor test your vitamin D. It's very easy to restore your vitamin D levels. Why not test it and find out if you need more? Oops. Green tea, essentially, men who drink a significant amount of green tea have been shown to have more optimal rates of progression. For instance, in a meta-analysis of multiple studies in men with high-grade lesions, taking green tea catechins reduced the rate of progression in prostate cancer. From pre-prostate cancer to prostate cancer, from 23.1% to 7.6%. So drink a few cups of green tea per day. If you don't like green tea as a beverage, it's available as supplementation. Lycopene comes from cooked tomatoes. That helps support healthy cell division of the prostate, helps to regulate apoptosis or programmed cell death. They found that individuals with high intakes of tomato or tomato-based products were associated with a 10 to 20% decrease in prostate cancer. Lycopene also inhibits the development of new blood vessel formation that feeds cancer, a process called angiogenesis. So cooked tomatoes or things like pasta. And you could also get lycopene available as a supplement, but this is just another reason why a diet rich in good healthy fruits and vegetables, good healthy fats is important for us. One moment. Pomegranate. This has actually been studied. I'll talk about it a little bit later on in a combination trial. But individuals who ate pomegranate, either the juice or intaking the fruit, they showed that it substantially improved PSA doubling time from 15 months to 54 months in men with rising PSA levels after surgery or radiation. But this tells us that even when prostate cancer is treated, you could reduce the risk of reoccurrence with good, healthy diet. In men who do have prostate cancer, probably the most important thing is a supplement that I have no association with. It's produced by a company called Econugenics. It's called modified citrus pectin. There's over 80 studies on this, and it helps to support healthy cell transport. It's pretty complicated, but it binds to galactins. Those are proteins that cancer cells could attach to and be spread around. So by binding to galactins, it gives us opportunity for those cancer cells to attach to it. If someone's going to consider a supplement and they have metastatic prostate cancer, this would be my number one suggestion. Here's an example of how it works, for instance. So there was a study called the ASCO study where they gave 199 men with prostate cancer. Average age was 74. And they were randomly assigned to receive pomegranate seed, green tea, curcumin or turmeric, and broccoli versus placebo. They took this twice a day. What they found is that in the placebo group, the PSA levels rose by about 78% over that 6-month period. But in the supplemental group, they only rose by about 14.7%. So again, while you can take this in a capsule, these are all things you can incorporate into your diet that could be helpful for you. Soy. A lot of people are concerned about soy, but soy is a beneficial isoflavone. It's one of the things that can help regulate our epigenetics, our genetic expression. How will our genes control cell division and program cell death? And that goes back to the earlier things I mentioned too, such as curcumin and green tea. Those are all epigenetic regulators. And so, for example, in one randomized clinical trial involving 54 patients scheduled for a prostatectomy, they received 30 milligrams of a soy extract called Genistein per day. They had a 7.8% drop in their PSA levels compared to the placebo group that went up 4.4%. In addition, there were 2 small open trials using soy beverages that noticed a reduction in PSA increases in those with post-treatment PSA levels. An increase in post-treatment PSA levels suggests your prostate cancer is coming back. So that's not something that we want. Again, I can't say that soy is going to prevent reoccurrence, but these are all studies that point us towards ways we can manage getting into ourselves in a more optimal situation. Cruciferous vegetables, such as from broccoli, cauliflower, eat your salads as well. We mentioned one in that one ASCO study, broccoli. In one study, in individuals who are consuming a lot of broccoli or taking a broccoli extract for 20 weeks, showed a significant improvement in PSA doubling time, for instance. In addition, a meta-analysis of observational studies found that cruciferous vegetable consumption, such as kale, broccoli, and cauliflower, was associated with a roughly 20% relative prostate cancer risk reduction among men who ate the most cruciferous vegetables compared to men who ate the least. And so eat your cruciferous vegetables is all I could say. Cranberry, not only can cranberry be helpful for prostate health, but it can manage complications from radiation, which urinary symptoms are a significant adverse effect for, and prostatectomy as well. And so drinking cranberry juice or taking a cranberry extract could help to manage the adverse effects of those treatment options. One of the ways that it does so is by managing inflammation of the bladder. Fish oil, we've already essentially talked about this. Fish oil regulates inflammation. It's part of a Mediterranean diet. You don't have to take fish oil if you're consuming a large amount of fish, but if you're not consuming any fish, it's just one way around it. So I'm going to mostly fly by this section. There's certain drugs that have found to work well with conventional treatment. These are called repurposed drugs. One of them is metformin, commonly used for diabetes, but it can help to support a more optimal prostate cancer mortality. And studies have shown that the longer that people with prostate cancer were on metformin, the better they did. Having more optimal metabolism through diet and exercise is one approach. But for individuals where that's difficult to do, it's easy for me to say, have a good diet and exercise a lot up here. But, if you have significant osteoporosis, injuries, if you're in a potential situation where you don't have a lot of control over that, well, telling me to do that isn't going to help you very much, is it? But metformin can be one option. It helps activate AMPK, a metabolic and cell division regulator. So that's one drug that's been shown to be helpful. Aspirin. Now, there's some controversy here, but aspirin does inhibit inflammation. And individuals who took more than 3 baby aspirin per week had a 24% lower risk of getting lethal prostate cancer. Statins also lower inflammation. They don't just lower cholesterol. In fact, likely one of their main benefits of cardiovascular risk isn't through their cholesterol lowering capabilities, but likely more so their ability to inhibit blood vessel inflammation. Well, again, recall inflammation is a driving factor in all chronic degenerative conditions. That includes cancer. So lowering inflammation through statins is one way that could be helpful. Excuse me. I want to briefly mention Ivermectin and Fenbendazole because I have this discussion at least once a day with someone asking, hey, should I take Ivermectin or Fenbendazole? There's a lot of controversy here. And I don't suggest these drugs. The controversy is that people in perhaps conspiracy groups or natural holistic groups have people suggest these drugs because they do have anti-cancer effects in test tubes and in animals. The problem is we don't have cancer studies in humans using these drugs yet. There is one study in breast cancer where they're using ivermectin in combination with conventional treatment, but we don't have any long-term studies. We don't know what the adverse effects are. We don't know how effective they are in humans. With ivermectin, the longest study that's been done in humans has only been 5 days. So we have no idea what the long-term complications of using these drugs are. In addition, cell culture studies shows that ivermectin, in regards to its anti-cancer activity, is least effective for prostate cancer compared to other cancer groups. I would also say, at least anecdotally, in the different prostate forum groups that I'm a part of, is that fenbendazole doesn't seem to be very effective. So the jury's not out here. Research needs to be done, but right now we don't have that research. I do not suggest these drugs. You're in uncharted activity. The only reason I bring this up is because I get asked about these literally every single day. So that's actually it for my presentation. I'm here to answer any questions you have, and hopefully I can answer them.
There are some questions in the chat.
Oh, I didn't see the chat. Let me pull that